And GERD is functional dyspepsia is one of the differential diagnoses. GERD is one of the differential diagnoses. Biliary colic, bile stone, gallstones, or acute cholecystitis, acute pancreatitis, or even acute MI. These are the differential diagnoses when you're dealing with upper abdominal pain. It's not just gastritis or acidity. Uh, Upper abdomen, the epigastric pain syndrome again is a big topic. Epigastric pain syndrome, a lot of differential diagnoses fall into that. So how do you diagnose these patients? Usually we used to do barium solo, barium meal, barium series we used to do. But then after the endoscopy came, we are not doing any more of these barium business. So we just put a tube and you'll know the diagnosis. You can't miss in an experienced hand. So endoscopy is a very useful tool to differentiate between ulcer or non-ulcer type, or even if you are having gastric outlet obstruction, you can pick up the ulcer size, number, size, site, everything can be known if you are doing an endoscopy. So one of the old dictums is Schwartz. Mr. Schwartz said, no acid, no acid, no ulcer. No acid, no ulcer. That holds good also. If there is no hyperacidity, there is no ulcer. He used to say, olden books, you see, no acid, no ulcer. That is. So, and treatment for H. pylori infection also is a big controversial area. When to treat, how to treat. Because every patient that is coming to you, you are doing a H. pylori test, that's rapid urease test or a small biopsy. If H. pylori is positive, do we have to treat or you don't have to treat? If ulcer is there, we have to treat. Our ulcer is not there, we need not treat, because the other family members will also be having this, and this tends to recur. And eradicating the H. pylori infection is extremely difficult. So we have to think twice before starting the triple therapy for this H. pylori related infections. So what are the treatment? In the treatment, you have one is eradication of H. pylori with the triple therapy, that is a clarithromycin, amoxicillin, and proton pump inhibitors at least for 2 to 3 weeks. Clarithromycin, amoxicillin. This because it's a bacteria. You have to give antibiotics. Then acid neutralizing agents. Of course, you have to give acid neutralizing agents. It's a problem of acid. No acid, no ulcer. So acid neutralizing agents or acid inhibiting drugs. One very important group is antacid. Antacids, they give immediate relief. And number two is H2 receptor antagonist, like your ranitidine and famotidine, etc. Third and very important, most effective group of drugs is your proton pump inhibitors. The proton pump inhibitors, the omeprazole, rabeprazole, pantoprazole, esomeprazole, all these drugs are used just like water. Again, every patient that is coming to us, we use these proton pump inhibitors. We are overusing these unnecessarily for every patient that is coming to us. So there are definitive indication when you have to give proton pump inhibitor. You just cannot use blindly to all these patients that are coming to you. Out of all these antacid, H2 receptor antagonists, and proton pump inhibitors, the PPIs are very most potent drugs for the treatment in the treatment of acid peptic disease. And mucosal protecting agent, that is the third one, is acid neutralizing, and second is mucosal protecting agents. Mucosal protecting, there is a cytoprotection. They protect the damage of the epithelium and mucous membrane. Sucralfate is one very important drug. When you give a sucralfate, either tablet or a syrup, a liquid, it forms a protective layer over the gastric mucosa, and the acid-related injury is prevented. So sucralfate is very good mucosal protective agent. And we also have prostaglandin analogs like misoprostol and bismuth containing liquids. So these are the mucosal protecting agents. So how do you diagnose this? As I said, endoscopy. If endoscopy, you diagnose, it depends on the size, site, what is the plan of the treatment. Is it only medical treatment, or does this patient require any surgical intervention? So surgical intervention, As I told you, if we used to do gastrojejunostomy. Gastrojejunostomy will be something like this. Can you show this here? Side. This is your stomach. If I want to say in Arba's language, this is my stomach. This is my stomach. Okay, there's a big ulcer here. The food is coming and damaging the ulcer further. So what we do is we remove this duodenum and we attach here. The food comes like that, and this is bypassed. The food does not come in contact with the ulcer in the duodenum. The food comes directly in, enters the small intestine. This is called gastrojejunostomy. Jejunum is pulled and they make a hole here, and the anastomosis is done between the stomach and the jejunum. This is called GJ, gastrojejunostomy. That is one. There are two, three, Billroth 1, Billroth 2. There are many types of this surgical procedures. Again, that is number one. Number two, we also do vagotomy. We cut the vagus nerve that is coming to the supplying the stomach. If you cut the vagus, the acid production also is reduced. Again, there are a lot of complications, but vagotomy is we are not doing anymore. The GJ and vagotomy we are not doing anymore. Previously, they used to do both GJ and vagotomy, and selective vagotomy, high vagotomy. There are again many types of vagotomies. So that is the surgical treatment for acid peptic disease. These days, we are rarely using these things. Again, if you want to know the exact, is it a simple benign ulcer or a malignancy? Whenever you are doing a endoscopy, you take a bit of the tissue to see whether are we dealing with some kind of malignancy or not. And the complications, as I said, the surgical procedure, beautiful complications are there. Afferent loop syndrome or blind loop syndrome or dumping syndrome. The dumping syndrome is, this is a blind loop syndrome. Blind loop means this blind loop, he gets infection and the things. And dumping syndrome is the moment the food comes here, it goes directly into the jejunum, taking very less transit time in the stomach. As the hyperosmolar food goes down into the jejunum, see, it absorbs a lot of water into the lumen because this is a hyperosmolar chyme. It absorbs a lot of fluid from the blood into the lumen, causing loose motion, and your plasma volume in the blood is less, so you'll have hypotension. Immediately, if somebody comes, many people say that they're feeling giddy, they're feeling like falling down immediately after they eat. So this is a dumping effect or dumping syndrome, we call it as. The food is dumped directly into the jejunum, causing the hyperosmolar food absorbing more water, thus causing the hypotension because of the hypovolemia. So somebody having giddiness and fall, like syncopal attacks, immediately after food, you can think this is usual complications of these surgical procedures. The blind loop syndrome and the dumping syndrome are the complications of these gastric related surgeries. Interesting area.